globalization of Korea.
The 1980s was a period of economic growth and full-scale globalization in Korea. Mega events such as 1988 Olympics brought the country to the forefront of the international community, while liberalizing international travel and increasing private international exchange. However, these changes also brought about a shift in the prevalence of disease. Previously, the main focus and concern about the disease in Korea, particularly infectious diseases, had been on endemic diseases that were prevalent within the country. However, with increased international exchange, people began to pay attention to disease coming from abroad. As Keijo, now Seoul, was named the sixth city in empire, the Korean peninsula during the Japanese occupation was seen as a major conduit for disease to the Japanese mainland. Sanitation and the subsequent control of disease were directly linked to the modernity, and colonies that failed to do so adequately were seen as backward. In reality, there were more cases of foreign-born infectious diseases such as cholera coming to the peninsula from mainland Japan, which had a high volume of overseas trade. Yet the perception that an unhygienic peninsula would export disease stuck not only in Japan but also in Korea. Attempts to use the Korean peninsula as a great wall against the diseases entering mainland Japan were adopted not only for human diseases but also for animal infectious diseases such as rinderpest. The perception of an unhygienic Korean peninsula contaminated with various diseases during the Japanese occupation and the infectious diseases that were spreading overseas through it was carried over to the US military government in 1945. Not only did the US military consider it likely that US troops stationed on the Korean peninsula would contract a variety of endemic diseases, but also that endemic diseases such as malaria and intestinal worms would be introduced back home upon their return to the US. In fact, this risk became a reality as cases of localized malaria infection were reported in North America by veterans who have been stationed in Korea. This perception of risk was dramatically illustrated by the fact that US military command prohibited deployed soldiers from eating local food and airlifted all foods and water from Japan that was deemed to pose a risk of intestinal parasite transmission. Infectious disease researchers and the public in post-war Korea also embraced this narrative, believing that a peninsula covered in roundworm eggs symbolized the country's backwardness. At the same time, these endemic diseases were seen as an impediment to the progress of Korean society and something to be ashamed of both nationally and personally. However, the Korean military's entry into the Vietnam War in 1964 reversed this perception and created an opportunity to project them abroad.
Recognizing foreign disease.
On the one hand, this expansion into the tropics led to the creation of new spaces for tropical medicine research. In 1966, the Institution of Tropical Medicine was established at Seoul National University and Yonsei University Medical School, respectively. The rationale for the establishment of these institutes was that tropical diseases could be easily introduced into Korea as part of Korea's expanding involvement in Southeast Asia and the Vietnam War, and that there was a need for institutions that could specialize in researching and responding to them. Especially in the 1970s, as the constant movement of people from and to the tropics began to surge, interest in tropical medicine or diseases that could be exposed abroad and brought back to Korea began to surge. This was also driven by changes in the global economic structure. After the war in Middle East in 1973 and the subsequent first oil shock, the long-term boom began in the oil-producing countries of the Middle East. This began to make large-scale social investments based on oil money. After Samwan Corporation was awarded the Saudi Arabian highway project in 1973, large-scale construction projects such as Libyan waterline project and Saudi Arabian port construction were undertaken. The number of Korean workers sent to the tropical Middle East increased. According to one survey, the number of overseas dispatched laborers was estimated to have reached 1,130,000 from 1963 to 1983. And in 1984, 150,000 were dispatched, with more than 90% of them dispatched to the Middle East. Concerned about the health care of expatriate workers and the weak quarantine system for returning workers raised fear that new diseases could be introduced. Indeed, new cases of parasitic infections that had not been reported in Korea, such as schistosomiasis and leishmaniasis, continued to be reported. Parasitic diseases typical of the tropics, such as schistosomiasis and leishmaniasis, were unlikely to become endemic in Korea because the vectors that could transmit them did not live here. Nevertheless, Korean doctors had never seen these tropical diseases before, so returning workers were often misdiagnosed with other conditions. One particular concern was the possibility of malaria returning. Considered to be nearly eradicated in the 1980s, malaria could become a major health problem if it were to be reintroduced to Korea. Furthermore, the malaria that could be introduced from Africa would be a tropical falciparum malaria, which was more deadly than the vivax malaria that had previously been prevalent on the Korean peninsula. Emphasizing the potential for the return of eradicated infectious diseases, scholars have called for an active incorporation of tropical diseases into Korean quarantine system. From the workers' perspective, the generally poor healthcare conditions in the stationed area also contributed to the high frequency of exposure to these diseases. While each company's construction site had an infirmary, the quality varied. Some sites could have not only nurses but also doctors, but rarely they had sufficient medical staff, facilities, or equipment, and most did not have personnel with specialized knowledge in tropical diseases. A 1985 awareness survey of expatriate workers in the Middle East found that 30.4% had never heard of any of the names of diseases prevalent in their assigned region. Furthermore, 78.5% had learned about tropical diseases from their peers, and only 22% had learned about them through company-provided training program or other media. The very real threat of infectious diseases from abroad was increasing as society became more international and large-scale population movement across borders became commonplace, but the response was left to the individual.
Emerging infectious disease.
As the Middle East construction boom faded in the 1980s, large-scale labor dispatches also declined. However, cross-border movement of the general population increased. This was due to the gradual convenience of international travel from 1981 and afterwards. The Korean government placed strict regulation on going abroad for civilians until 1970s, whereas workers sent abroad in the 1970s were provided with minimal health checks through overseas development agencies and some degree of follow-up after returning home. Travelers were not subjected to such post-return quarantine measures. And there were concerns that they could become a conduit for the introduction of endemic diseases from abroad. While the opening of international travel made disease from abroad be observed by the general public, they remained largely a private matter. However, a series of mega events planned by the government in the 1980s to showcase Korea's economic achievements publicly, the 1986 Asian Games and the 1988 Seoul Olympics, meant that the issue of foreign-born infectious diseases could no longer be dismissed as a private matter. The Seoul Olympic Organizing Committee, which was sent to prepare for the 1984 Los Angeles Olympics, included experts in endemic disease research. The Korean media conveyed the public's interest and concern, stating that we cannot always be safe. The 1980s also observed the emergence of a number of infectious diseases that were unfamiliar to Korea, including AIDS, which was newly introduced in the 1980s. In some cases, the exact time of introduction was unknown. But the pathogens were identified during outbreaks in the 1980s due to advance in medical knowledge and technology or other environmental factors. For example, Vibrio sepsimia in 1982, Legionella and leptospirosis in 1984, and Tsutsugamushi disease in 1986 were all diseases that were introduced before the 1970s or had been presented in Korea for a long period, but their causes were only identified in the 1980s. In a way, it can be argued that the development of Korean medicine has allowed these diseases to come to light, with its increased capacity for diagnosis and testing, and systematic epidemiological investigations. On the other hand, the revised Infectious Disease Control Act of 1976 made it mandatory for doctors to declare and report statutory infectious diseases to the government, and forced systematic epidemiological investigations. Legionella is a bacterial infection spread by contaminated cooling tower water in air conditioning facilities. In Korea, an epidemiological investigation by a team of preventive medicine identified that causative agent after an outbreak in the intensive care unit of Korea University Hospital in July 1984. Further investigation of large buildings in downtown Seoul revealed that at least 7 cooling towers contained the Legionella, and this suggested that the disease was already indigenous to the country. Nevertheless, newspaper editorials treated diseases such as Legionella and Leptospira that were already indigenous to Korea, but whose causes were not identified until 1980s, as if they were newly introduced. They also reported that foreign endemic diseases were being brought into the country because of the increase in overseas employment in the Middle East, Africa, and elsewhere. This presented that the public's interest in infectious diseases from abroad was growing along with the increase in overseas exchange.